We are live now. I'm sharing the screen, sir. Good evening, everybody. Those who are present here through virtual medium, or the people, those who are seeing us through our websites, a very, very warm good evening to each and everybody. As the wait, all of you, we have been receiving a lot of messages related to when the episode 2 is coming. So here it is. A very warm welcome from my side. I, Piyush Shukla from Corona Remedies, welcome you all in the Banker IVF and Women's Hospital present webinar series on up-to-date guidelines-based fertility treatment by episode 2 by Dr. Joanne Banker sir on unexplained infertility. So as the tradition goes, I'd like to start our day, our session, this webinar, our episode 2 by the lamp lighting ceremony. Dr. Joel Banker, sir. The person needs no introduction as he is very well known personality across India, the young, the dynamic, and the shining face across India. But yet, I'd like to mention few of his many achievements. He is Dr. Joel Banker, consultant banker, IVF and Women's Hospital, faculty at Gujarat University for MSc in embryology. His areas of interest are various, but some of which are IVF related immunology, recurrent IVF failure, reproductive genetics, and hysteroscopy. He has several achievements, but some of which are creators of India's first savior sibling using IVF, PGT, and HLA matching. Training in IVF and reproductive genetics. He has 12 publications and 3 book chapters. A very warm welcome, sir. People are waiting for you. Hence, I'd like to hand over the session to you. Please continue, sir.
Thank you so much for the warm introduction. So my topic for today would be unexplained infertility. These are the most recent guidelines given by the European Society, ESHRE Society. And every year, some or the other international committees give new guidelines on different topics, one of which is unexplained infertility, to clear some doubts which were there previously. So today, let's see what all changes were there compared to the previous guidelines and what we should do for our patients according to guidelines if they have unexplained infertility. So introduction, very basic, but infertility is defined as the failure to achieve a clinical pregnancy after 12 months of regular, unprotected sexual intercourse. It can be considered 6 months in women who are elderly, that is more than 35 years. Infertility is unexplained when standard infertility testing has not found a cause for a couple's inability to get pregnant. So, I mean, this is where we call it unexplained infertility. The ASRM 2020 guidelines suggest that of the couples experiencing infertility, up to 30% are diagnosed with unexplained infertility after a standard evaluation. Now, this standard evaluation will include demonstration of at least one patent fallopian tube, documentation of ovulation in the female partner, and a semen analysis with an adequate number of motile sperms for the male partner. So, if these three are normal and still the couple is not able to get pregnant, 30% of cases are such and they are called to have unexplained infertility. So, definition according to the ESHRE working group and the ICMAT guidelines is unexplained infertility is the infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, pelvis, and with adequate coital frequency, and apparently normal testicular function or genitourinary anatomy and a normal ejaculate. So this covers most of the things as we can see the uterus, cervix on a transvaginal ultrasound. With adequate coital frequency is very important because only 6 months or 1 year of unprotected intercourse is not the only thing necessary. They should have an adequate coital frequency and normal anatomy also in the male partner. The potential for this diagnosis is dependent upon the methodologies used and those methodologies available to uncover certain causes of unsuccessful attempts at pregnancy. So, unexplained infertility is inevitably a diagnosis of exclusion. We have evaluated everything that we can. This depends on the methodologies used, but still, if they are not able to get pregnant, it is unexplained. The ESHRE 2023 guidelines state that infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, pelvis, age less than 40 years, and with adequate coital frequency, and normal testicular and genitourinary function, and an ejaculate. So they have added another criteria of age less than 40 years, because as we know, as the age increases, the chances keep on decreasing more and more. So ICMAT guidelines tell that the couple should have at least 12 months of regular unprotected intercourse before investigations are initiated. So is unexplained infertility really unexplained? Many things are not really addressed. That is the age or the BMI of the couple. Ovarian reserve testing, is that necessary to call infertility as unexplained? Tubal patency may not represent tubal function. If the tubes are patent, it does not mean that the tubes are able to pick the eggs on time or transport the egg or the sperm on time, give adequate environment for the embryo to develop. So we still don't have functional dynamic tests to test for tubal functionality. Endometrial receptivity is not addressed. Subtle pathologies like minimal endometriosis or mild PID can give rise to certain peritoneal factors also. And these things are not assessed because they are not evaluated regularly. And uterine cavity abnormalities cannot be fully evaluated without 3D sonography or a hysteroscopy. So these guidelines aim to address certain issues which are unaddressed in the previous ones. Other causes include immunological causes, lifestyle causes, sexual frequency and timing, because we don't know the exact frequency needed, and still many complex steps in fertilization, like the capacitation ability of the sperms, the zona pellucida interaction, the bidirectional tubal motility. These are all dynamic and functional tests, and hence they're very difficult to evaluate in a couple. So the term unexplained infertility ranges from not so easy to diagnose to not so well understood. It is some on the side of the science, some problems are methodology dependent and observer dependent. So today we will go through how do you diagnose unexplained infertility, like confirmation of ovulation, oocyte quality, ovarian reserve testing, tubal factor testing, uterine factor testing, laparoscopy, cervical vaginal factors, male GU system anatomy, additional tests for male partners or other systemic conditions. And we will also look on the treatment options, what the guidelines suggest, expectant, active, any mechanical or surgical procedures, or are there any alternative approaches? So confirmation of ovulation, which is the reliable and convenient method to confirm regular ovulation. We know many things are available, starting from basic menstrual history to having regular periods, then menstrual history plus serum progesterone levels, a sonography, urinary or blood LH levels, only urinary LH levels, only ultrasound, cervical mucus basal body temperature method. So, which is the method of testing should be reliable and should be convenient. Either if it is only reliable and not convenient, it is not very useful. If it is too convenient but not reliable, then also it is not useful to include in the criteria of unexplained infertility. And the guidelines suggest that in women with regular menstrual cycles, tests for confirmation of ovulation are not routinely recommended, because only if the ovulation is normal, then the patient is going to get regular menstrual cycles. But in women with regular menstrual cycles, if confirmation of ovulation is warranted, then tests such as either urinary LH measurements, ultrasound, or mid-luteal progesterone measurements all can be done because they are quite accurate to some extent. But in clinical practice, ovulation is seldomly confirmed using basic fertility workup. If at all, if at all it is done, it is better to confirm with a more reliable test like ultrasound monitoring or LH test, as basal body temperature presents with a very low accuracy, and this was also found to be less acceptable to patients. Right? So in regular cycles, no routine requirement to test confirm ovulation, but if needed, then ultrasound monitoring or a urinary LH measurement is good enough. Next, we look at oocyte quality. So what is the reliability of parameters detecting good oocyte or corpus luteum quality? Many people test for a mid-luteal progesterone to see how the egg quality was, whether it was more than 15, more than 20, whatever cutoff they have. Or many people do endometrial biopsies in the late menstrual phase to see how the endometrium responded to that good egg which has come up during ovulation. But same, in women with regular menstrual cycles, it is still not advised to do mid-luteal serum progesterone levels, as it is not very essential. Endometrial biopsy for histological examination is not recommended in the absence of other indications. So many other indications, if you have suspicions of polyps or any other endometrial lesion, then you might need to do an endometrial biopsy. And in the same setting, you can confirm this also, but as such, it is not needed. Even in the presence of a threshold of mid-luteal serum progesterone level, below which the pregnancy and live birth rate are decreased, is assumed, there is no evidence showing that increase in live birth rates with exogenous progesterone in any form. So many people believe that if the progesterone level is less than 10, then there is very less chance of pregnancy. But studies have failed to demonstrate that in spite of giving more progesterone, the pregnancy rates increase. So this recommendation does not apply to women who have an indication for endometrial biopsy like endometrial hyperplasia. But in routine, in pregnant women or in women who are ovulating normally, there is no need to test for egg quality, as age is primarily the main indicator of your oocyte or the egg quality. So should one or more tests of ovarian reserve be included in the diagnostic workup? And many tests are available, starting from a blood test of AMH, to antral follicle count, to clomiphene cited challenge test, ovarian volume, ovarian blood flow, or day 3 hormone assessments. We feel that if there is something wrong in the ovarian reserve, this might lead to unexplained infertility. But let's see what the guideline states based on the various studies available. So in a cross-sectional study, AMH, FSH, AFC were compared between women who had strictly defined criteria of unexplained infertility and 200 control women. And the women were of reproductive age between 25 to 40 years. They had a serum FSH value of less than 12 on day 3, which means that the basic status was normal. And adjusted analysis showed that AMH, age, VFC, AMI was equal in both the groups. And in women, it uh, concluded that in women with regular menstrual cycles, ovarian reserve testing is not required to identify the etiology of infertility or to predict the probability of spontaneous conception over the next 6 to 12 months. So the term ovarian reserve refers to the quantity of primordial follicles in the ovaries at a given time. And although this term has been used in a broader sense, like we use it to counsel the patients regarding egg quality, the number of eggs, the chances of pregnancy they have. But it is very difficult to assess the oocyte quality during this diagnostic workup. And most of the listed studies consistently show that the ovarian reserve status is not predictive of a spontaneous conception over the subsequent 6 to 12 months. As long as they maintain regular cycles, they have similar pregnancy rates. All have seen that normal pregnancies do happen randomly, even if the AMH is very, very low, less than 0.2, 0.3, or even if the AMH is high, more than 4 or 5. So AMH as such or ovarian reserve does not predict the chances of spontaneous conception anytime in their fertility life. It only tells us the urgency they have to plan a pregnancy. Next, let us see about tubal factor. So what is the accuracy of the commonly used tests available for tubal patency? It can be HSG, hysterosalpingography, laparoscopy, a HICOC using contrast media, or a HIFOC using foam. Foam is not very easily available here, but quite broadly used abroad. So high risk for tubal occlusions include past infections of chlamydia like PID or peritonitis, known endometriosis, or a history of pelvic surgery, including a salpingectomy for an ectopic pregnancy. So chlamydia testing, if you suspect pelvic infections in the past, chlamydia antibody testing for tubal patency can be considered as a non-invasive test to differentiate patients who are at a low risk and a high risk of tubal occlusion. If you don't suspect any tubal occlusion, there is no need to check for the tubal status of that woman. And in patients at high risk of tubal abnormality, visual demonstration of tubal patency is necessary. By visual demonstration, it only suggests using laparoscopy, hypoxia, less likely by HSD, and there can be certain other problems also. HSG, hypoxia and HSG are valid tests for tubal patency compared to laparoscopy and chromoperturbation, but HSG and hypoxia are comparable in their diagnostic capacity. So the selection of the technique will depend on the preference of the clinician. Still, we'll see later on that an oil-based contrast is better than a water-soluble contrast, which is used for HSD, and this can lead to certain false negative or a false positive report. Hence, hypoxia or a laparoscopy are better methods. Still, any method can be used, but only use it when you suspect some tubal occlusion in that patient. Next, let us go on to uterine factors. So, which diagnostic procedure should be performed to confirm a normal uterine structure, anatomy, uterine wall, or myometrium? Sonography, MRI, HSG, many things are available. Ultrasound, preferably 3D, is recommended to exclude uterine anomalies in women with unexplained infertility. Now, I feel in this day and time, will almost all machines come with 3D functionality. Doing one 3D scan for all couples in their mid-follicular phase when they come here will help you evaluate the uterine cavity to a very large extent. And we can avoid certain things which we come to find out after a year of giving them medicines. MRI is not recommended as a first-line test to confirm a normal uterine structure with unexplained infertility. If ultrasound of the uterine cavity is normal, then no further evaluation is needed. I mean, your ultrasound should be your mainstay. There is no need to subject a patient to a hysteroscopy or an MRI if you have done a good 3D scan of that woman and you feel everything is normal. You can identify polyps, septums, micropolyps, adhesions, everything using good scans. So that should be your primary objective to evaluate completely using ultrasound. And the routine diagnostic laparoscopy is not recommended for the diagnosis of unexplained infertility. Do it only when you are suspecting tubal occlusion and you opt for doing a laparoscopy compared to other methods. Then what is the need to test for other female lower genital tract investigations? Many other investigations are done for cervical factors, vaginal factors, most common being a postcoital test. But in today's day and time, we know that postcoital test is not recommended in women. Very difficult to do, very uncomfortable for the woman with no guidelines and no positive predictive value. But a very interesting aspect has come up in recent times, that is vaginal microbiota or vaginal flora. Very few studies have come up. And these studies find it very difficult to investigate the role of vaginal microbiota due to different detection methods used. So some studies use a wet mount microscopy, some use Spiegel's criteria, Nugent scores, or advanced testing using qPCR assays. Additionally, vaginal swabs are taken from different points of time during the menstrual cycle, sometimes in the follicular phase, before and after ovulation stimulation, at the time of egg retrieval. And lactobacilli dominance is also defined differently between papers. So we don't have exact guidelines on what to see and unanimity in the papers. So currently, there is insufficient evidence to suggest a role of abnormal vaginal microbiota in unexplained infertility. But this looks promising, and further studies will help us evaluate it better. So vaginal microbiota testing could be considered in couples with unexplained infertility, but only in a research settings. So no need to perform vaginal flora transplants right now. We are still at a research stage. We should still wait and see what the guidelines and other studies tell us. Now we move on to male systems. Should men undergo additional diagnostic procedures to confirm normal genitourinary systems before being diagnosed with unexplained infertility? So what are the different tests available? Semen analysis, ultrasound of the testis, anti-sperm antibody testing, DNA fragmentation index, chromatin condensation tests are also being done to indirectly check the DNA integrity of the sperms. Many hormonal tests are also being performed, like testosterone or LH levels, or other tests like semen microbiology to see if there is any infection in the semen which can cause infertility. Let's see what the guidelines tell us. So our primary mainstay is semen analysis, and all other points in these recommendations are based on semen analysis. Testicular imaging is not recommended when semen analysis is normal. Anti-sperm antibody testing is not recommended when semen analysis is normal. All are strong recommendations. So there are plenty of good quality articles available in the literature. Sperm DNA fragmentation is also not recommended when semen analysis is normal. Chromatin condensation test, serum hormonal testing, or microbiology is not recommended. So primarily, if the semen analysis is normal, these things are sporadic. Sometimes the DNA fragmentation can be high, sometimes it can be low. Sometimes because of hormonal variations, there might be some variations in the hormone. Infections can happen, but these will eventually go away. Our endpoint is a normal semen analysis. So if the anatomy is normal and the semen analysis is normal, you don't need to continue with your investigation. Check the semen analysis 2 times in a gap of around 1 to 2 months. If both are normal, you can well as well tell the couple that the male partner is normal. And what about additional tests? There is no limit on how many tests we can do to further complicate the matter or to diagnose unexplained infertility. So testing for anti-sperm antibodies in serum of either males or females is not recommended. There are some studies which had shown earlier that women with celiac disease or certain other immunological conditions are at a higher risk of infertility. So many couples, many studies have tried to identify a correlation between that. But overall, if you look at all the studies together, these guidelines compare all the analysis and they come up with the answer that even testing for celiac disease in women is can be considered because newer evidence shows and patients can be counseled to go for further genetic testing. So this is a conditional uh, guideline, not a strong positive value guideline. What about thyroid hormones? Do you need normal thyroid hormones to identify a woman with unexplained infertility? Do you need further testing like uh, thyroid antibodies or anti-TPO antibodies? What all tests are needed? So as a rule, I mean, a thyroid workup is already done when a patient comes to you. If the TSH levels are normal, the good practice guidelines state that the TSH measurement is considered good practice in preconception care. Right? If the TSH is normal, you can assume that the thyroid function is normal. But testing for thyroid antibodies or other autoimmune conditions apart from celiac disease is usually not recommended because thyroid antibodies has no correlation with unexplained infertility. TSH measurement is good, and no additional thyroid evaluation is recommended if the TSH is within normal range. Many people test for T3, T4, TSH, and anti-TPO antibodies at the same time. This adds on to the cost of the patient, but the ultimate factor is a normal TSH level. The TSH can self-regulate itself in spite of other factors being normal or abnormal. So if the TSH is normal, you don't need to subject the patient to further thyroid testing. What about thrombophilias? Antithrombin 3, protein C, protein S, methyl tetrahydrofolate reductase mutation, hyperhomocystinemia, lupus anticoagulant or APLA test. Some tests are being done for recurrent pregnancy losses, but are these tests essential when you want to diagnose the patient as unexplained infertility? Let's see what the guidelines tell us. So, good study in 2012 showed that women who had APCR or factor 5 laden or antiphospholipids who had significantly higher live birth rates in comparison to women who were tested negative. So, this suggests the opposite thing. So, if the patient has unexplained infertility, there is no need to test the couple for thrombophilias. Yes, thrombophilia and other factors can play a role when the couple is having pregnancy losses, but in when the couple is not able to get pregnant, testing for thrombophilias does not give us additional information which will help us treat that couple, right? So keep the investigations to a minimum according to guidelines, reduce the cost and the burden to the patient. Do only tests which are actually recommended so that you can treat them better. Same goes for other tests like genetics or genomics, prolactin, vitamin D. Many couples still believe that vitamin D plays a big role in unexplained infertility, but studies have also shown contrary results, like patients with vitamin D deficiencies or vitamin D surplus had similar pregnancy rates. Prolactin, if the prolactin is deranged, then there will be a problem in the ovulation. And clinically, you can check for ovulation problems. If you feel there is some problem in the ovulation, you can go for prolactin testing to rule out certain causes. But when you classify a patient as unexplained infertility, which means that she is ovulating normally, you don't need to test for prolactin, vitamin D, or advanced genetic testing like microarrays or next generation sequencing or karyotypes just to find out because all other factors are normal. So this covers our diagnostic parts of unexplained infertility. Next, let us look at the management strategies. What all are available? What should be our goal? So expectant, active, mechanical, or alternative. Let's look at expectant management. So what is the role of expectant management compared to active treatment for patients with unexplained infertility? Expectant management could be do nothing, just wait and watch. It can be giving clomiphene to induce ovulation or letrozole and then subjecting the patient to timed intercourse. It can be giving gonadotropins and timed intercourse. It can be a natural cycle IUI in which the patient ovulates normally and we do an IUI after she has ovulated, or it can be ovarian stimulation IUI. Some papers consider this as an expectant management, some consider this as an active management. So we will consider this in both the parts when we discuss our treatment options. But primarily, timed intercourse with or without medication or a natural cycle IUI can be considered as expectant management. So the weight of the evidence strongly suggests that IUI with ovarian stimulation is recommended in preference to expectant management, particularly for couples with poor prognosis. Although IUI involves obviously more invasive treatment, the difference in the live birth rates between the two alternatives provides justification for its use. And latest studies show that only a low dose regimen should be employed if you are using gonadotropins, or you can use only oral stimulation since it can reduce the risk of multiple pregnancy rate without significantly reducing the risk of live birth rate. So many important points are covered in these three statements. If the patient is having regular intercourse since more than a year, then by doing nothing, you aren't actually improving the chances of a pregnancy. The patient is ovulating normally. So only ovulation induction using medication is not going to give you the results you are expecting because she is ovulating. Giving timed intercourse is also not very essential because if the sperm count and everything is normal, then the sperms can survive for 3 to 5 days inside the woman's reproductive tract. So many things point that just by giving medicines or just by doing timed intercourse, you are not improving the chances of pregnancy. Ovarian stimulation is important to some extent because you can have more than one follicles, either two or three. Don't overdo it with gonadotropins, as we don't want more than 3 or 4 follicles. As what we want is a good single or twin pregnancies. We don't want multiple pregnancies like triplets or quadruplets. So mild ovarian stimulation will increase the chance because of more follicles. Triggering will increase the chance of good ovulation. And if there are certain cervical factors or any other factors or borderline sperm factors, you are also processing the sperms and doing an IUI. So if by doing an IUI, we will cover all the basic parameters needed in such couples who have unexplained infertility. And this should be our primary objective when the patient comes to you after 1 year of trying. IUI with ovarian stimulation is recommended as the first line treatment for couples with unexplained infertility. The guideline development group advises to base the decision to start active treatment on the prognosis of the couples with unexplained infertility. So if you want to start active treatment, the patient is very young, 22, 23 years, and comes to you, but I still want to wait for the 6 months, you can wait. The chances of a spontaneous pregnancy are also very high because the prognosis of the patient is good. Patient is young, good fertility status, regular ovulation, good semen count, good coital frequency. If the patient is 32 years and comes to you, you should advise her that she has an active need for more aggressive treatments like an IUI because of her age and other associated factors. So this should be counseled and decision should be made accordingly. So active treatment is pursued. Which type of active treatment is good? Clomiphene with time intercourse, letrozole, gonadotropins, natural cycle IUI, ovarian stimulation IUI, or IVF. So same IUI with ovarian stimulation is the first line treatment. The choice of clomiphene versus letrozole, both of them are given equal weightage in these guidelines as both are used to induce ovulation. If you are more comfortable with clomiphene, you can continue with that. If you're more comfortable with letrozole, you can continue with that. Letrozole has a monofollicular development, so you reduce the chances of multiple pregnancies by giving letrozole, and you have a good endometrium when you give letrozole because the clomiphene acts negatively on the endometrium. So these things depend on the clinician, their experience, their choice. But studies have shown that both of them can give equal pregnancy rates. Your end point should be to avoid multiple pregnancies and OHSS if you are giving gonadotropins. If you use gonadotropins, use only in a lower dose regimen and with adequate monitoring. We don't want a patient to get pregnant and have ovarian hyperstimulation. Right? Given the new ART guidelines, ART law also, this should be a very important point in our clinical practice. IVF is probably not recommended over IUI with ovarian stimulation in couples with unexplained infertility. So this is also a very important line. Just because the couple has unexplained infertility, IVF should not be your recommendation over IUI, but the decision to use IVF should be individualized based on the patient's characteristic, such as their age, duration of infertility, previous treatment, or previous pregnancies. So IVF is not a second line treatment. IVF is not the first line treatment. IVF is a separate matter and it should be addressed individually. So a woman comes to you with unexplained infertility, a couple comes to you 36, 37-year-old, and she has a low ovarian reserve, then you might advise her that IVF will give you a higher chance of pregnancy. If the patient comes to you, 30-year-old patient comes to you with a married life of 8 years, trying naturally for 8 years, then you can consider that IUI might not give her the chances of pregnancy as IVF will give them. So depending on characteristics like the patient's age, age is very important for egg quality and quantity, the duration of infertility or the duration of an active married life. This by itself is a very important indicator and a very important point which you should discuss with your couple when you advise them any treatment. Couple comes to you with 7 8 years of married life and you offer them a treatment of IUI with a 15% success rate, they might not be happy with it because they are already been trying since many years. And such couples can be offered IVF as the first line treatment also. Previous treatments and a previous pregnancy are other important individual indicators. So IUI in combination with OS is not inferior to IVF. Furthermore, the additional costs and risks involved in IVF need to be considered, so your treatment should be individualized. Therefore, IUI in stimulated cycles for 3 to 6 cycles is a good first-line treatment for couples with unexplained infertility. Now, taking this into account, low-dose gonadotropins for ovulation stimulation to avoid a higher number of growing follicles, which can increase the risk of multiple pregnancies or ovarian hyperstimulation syndrome. And the decision to use IVF is individualized by patient's characteristics. All three very important points and very clearly addressed. But the choice of gonadotropins can be yours and it does not make a difference in the patient's potential to get pregnant. Let us look at other mechanical surgical procedures like resection of fibroids, resection of polyps, endometrial scratching. So if the patient has polyps or fibroids, then the patient does not have unexplained infertility. So if you are suspecting something on an ultrasound, then you should obviously do an hysteroscopy to evaluate it. But hysteroscopy purely for the purpose of detection and possible correction of intrauterine abnormalities is not, which are not seen at routine imaging, is not recommended. So if the patient is not getting pregnant, don't tell them, let us do a hysteroscopy and see if everything is fine internally. Do a good 3D sonography to rule out all possible causes, septums, small polyps, multiple polyps, evaluate it for completely. If she has them, then she doesn't have unexplained infertility. Then subject her for a hysteroscopy and try again. Endometrial scratching should not be offered for unexplained infertility. Very strong recommendation. There is no role of endometrial scratching. Just because the patient is not able to get pregnant by doing a mild DNC or a hysteroscopy scratching will not increase the chance of pregnancy. On the contrary, it is a surgical procedure and it has a theoretical risk of introducing infection in the uterus or can even cause Asherman if not done properly or if done very severely. Endometrial scratching should not be done in such women. So last few slides. ASHRAE 2020, what we saw right now were the ASHRAE 2023 recommendations. 2022 recommendations were OS plus IUI as the first line treatment, gonadotropins only in low dose regimens to avoid hyperstimulation and multiple pregnancies. IVF is better over expected management, and after 3 to 4 cycles of OS plus IUI, HSG preferably should be done with a oil soluble contrast and a water soluble contrast, which is more accurate. Psychological support, including psychotherapy, what we call tender loving care, plays a big role. Healthy diet, regular exercise, behavioral therapy, all play a big role. These things cannot be pinpointed because the diet and exercise frequency changes from couple to couple, from country to country, from ethnicity to ethnicity, and from religion to religion. But all of them follow a healthy, regular lifestyle, then these will play a big role. Compared to the 2022 guidelines and the 2023 guidelines, most of the things have remained the same with regards to the first line treatment. Earlier, Clomiphene versus letrozole was a gray area. Now the guidelines have recommended that both of them have an important equal result in a pregnancy. Earlier, IVF was not included in the guidelines, or it was shown to be a second line treatment. These 2023 guidelines exclude IVF from the treatment. Either it is ovarian stimulation or not stimulation. So either it is an expectant management or you do IUI or IVF depending on other factors such as age, ovarian reserve, duration of infertility, etc. So do consider IVF according to the individual need of the couple. What is not recommended is CC, timed intercourse, natural cycles, IUIs, ICSI over conventional IVF. Both of them have still shown similar results. No role of endometrial scratching, no role of antioxidants, no role of inositols, no role of acupuncture. Even the current guidelines state this, and many studies are now not being done because there is enough evidence showing that there is no role of these adjunct treatments. It only increases the cost to the couple. The ASRM 2021 guidelines recommend clomiphene cited with IUI as the first line, letrozole with IUI as a second line. But these guidelines, because this is just because clomiphene is FDA approved, still both of them can be used. But the guidelines suggest that a single IUI should be performed between 0 to 36 hours of the trigger injection. Trigger with only HCG in an IUI. Don't use agonist triggers as it causes luteolysis. So mild stimulation, IUI with HCG trigger, normal urinary HCG or recombinant HCG, and a single IUI between any time between 0 to 36 hours of the trigger injection, as the sperms can survive for a few days. Low dose gonadotropins plus IUI is likely no more effective than oral agents. It is more complex, expensive, and has the risk of multiple pregnancies. What is not recommended is IUI in natural cycles, CC timed intercourse, anything with timed intercourse, or high dose gonadotropins with an IUI. So couples with unexplained infertility initially should undergo 3 to 4 cycles of OS with IUI. These are the 2023 guidelines. OS and IUI with oral agents. For those unsuccessful with OS and IUI treatments with oral agents, IVF is recommended rather than OS and IUI with gonadotropins. Try IUI with oral agents or add mild gonadotropins, but don't go for higher dose of gonadotropins. If you want to go for high dose of gonadotropins, it is better to go for IVF compared to an IUI. Up to date 2023 recommendations are 3 cycles of stimulation plus IUI with oral agents followed by IVF. A very patient has come to you for a pregnancy. Patient has not come to you for treatment. So deal with them accordingly. They will not wait for another 6 months or 1 year. Tell them to try naturally. I'll give you medicines. Go home and try naturally. Patient does not want that. They want a pregnancy. That's why they have come to you. So start active treatment. 3 cycles of IUI with oral agents. If the patient is ovulating nicely with oral agents, no need to add gonadotropins. If at all you need a higher dose of gonadotropins, it is better to counsel them to go for IVF. If IVF is unacceptable, then the decision should be taken to either go for a laparoscopy or a gonadotropin based IUI. This should be based on the clinician and the patient's preference. Two important points, very easy to utilize in our clinical practice. Our sonography is our mainstay. A good 3D scan is a must for all patients. If TSH is normal, don't do further testing. If the semen analysis is normal, don't go for further testing. No need for hormonal testing. No need for antibody testing. Ovulation is normal, uterus is normal, tubules are normal, sperms is normal. Go for 3 cycles of IUI with ovarian stimulation, followed by IVF if that is not successful. So very clear guidelines, very easy to implement in our daily practice. And thank you for attending this session. Let me know if you have any doubts so we can address them more in detail. You can also email me on my email ID if you have any doubts in your clinical practice. I'll be happy to help you in whatever way I can. Thank you so much.
Thank you so much, sir. Just give me 1 minute so that I can check is there any comments related to that. I'll
Sure.
also do one thing. I'll share the your email ID through the comment sections. I'll post it there so that if somebody has any kind of questions, so that they can directly mail to you as well.
Sure.
Yeah, just 1 minute, sir, please. Dr. Jaimin Kaur Dahiya from Vidarbh, she's saying that very informative session. I was kind of waiting for this. Thank you so much. And Dr. Santosh Panda, he's saying that it was quite informative and it was quite, what is this? Yeah, it was quite informative and at the same time, it was quite meaningful session. There's no as such questions specific, but
I just want to tell one thing. Like,
I'll post the email over there so that if somebody has any question, they'll directly mail to you,
if
sir.
you have any of you have any doubts regarding unexplained infertility or infertility in general, you can email me anytime. One thing I want to stress is what we usually practice here is a very peculiar way of practice that is our own personal experience. We don't trust guidelines. We tend to feel that, chalo, I had given this thing to 10 patients, all of them conceived. I did scratching for five of my patients, all five conceived. And so I will do it for all the patients. These studies take into consideration thousands of such patients. And eventually they give us a guideline. So we should not go the other way around it. Try something in our clinical practice and then continue to reinforce it. We should base our practice on guidelines which are based on many studies, which will eventually give you a better chance of pregnancy to your patients. So guidelines are very important. And do let me know if you have any queries.
Thank you so much, sir. It was quite a nice interacting with you and learning from you. And again, this is Piyush Shukla from Corona Remedies. Thanking you again for such a wonderful session and signing off. Thank you so much, sir.
Thank you so much for having me. Thank you.